My name's Kevin Mann. I'm the senior orthotist that works with the Spinal team with regards to bracing for scoliosis. By the time you get to see me, you'll have met one of the spinal consultants who will have made a decision for you to have a brace. That decision to have a brace will be dependent upon a number of factors, which the consultant will have already explained to you. The reason why you come to see me initially is that we can do basically what we call a brace run-up program, where we have around about an hour's period of time in which you can converse with me about the pros and cons of bracing and of what we can and can't do with the brace. Try to be as honest as possible, because ultimately it helps in the long run for you to understand what we're trying to achieve. And ultimately with bracing, as any spinal consultant will tell you, the idea of bracing is not to correct your curve, but to try and prevent the curve deteriorating to a point at which you need surgery sooner rather than later, or possibly not at all. So when you come to see me, you eventually come into one of the consulting rooms here on level 7 of the Children's Hospital. I'll introduce myself, take you into that consulting room, and we'll sit down for about an hour where we'll discuss bracing. You'll be given initially a small leaflet which explains a lot of the questions that you might want to ask. But ultimately, I always tell parents that while you're away waiting for the brace to be built, then if there are any questions you need to ask, just write them down on a piece of paper or electronically record them, so that when you come back for the brace fitting, then you've got all the questions other than the ones that have already been answered in the leaflet for you to question me on. The brace itself we use at Bristol is the Boston brace. Now, we do know there are other braces on the market. However, in Bristol, we've stuck with the Boston brace, partly because it's basically the granddaddy of all the bracing. It has the greatest amount of research papers on it, and we believe that it carries out the correct function for what we're trying to achieve. Now, when the Boston brace is actually decided upon, measurements are taken of you, and that requires just 4 measurements. 3 circumferential around your chest, your waist and your hips, and 1 across the actual width of your hips. From that, we then produce a brace. When it comes, we try and show this to you before you arrive to see this, because it becomes this size. And as you can see, it's somewhat big, okay? And it frightens most children to death, because they look at it and say, I can't wear that, it's impossible. But after 2 hours of work, it ends up like this. And this is what you would expect to see from a standard Boston brace module. It has an extension on the right hand side here, and it has a gap on the left hand side here. The idea is basically that it's going to press against your spine and push it from right to left. Most children with adolescent idiopathic scoliosis have a right thoracic curve and a left lumbar curve. So that's why there's an extension piece on the right hand side. And often we will put a pad inside as well to augment the amount of pressure onto the ribs and to straighten it. To make this normally takes about an hour and a half to 2 hours, so you're in the department for that length of time. It has on the back 3 sets of straps. Now, you will see some Boston braces that have Velcro straps on them. We tend to steer away from that because Velcro straps are very easy to undo. And we know that full well that if it's easy to undo, it will be undone. Whereas if we use sliding buckles, it's a lot easier to control and to stop you from getting out of it. Also, each strap will be marked for your parents and friends, so they know exactly how tight to pull the brace. The brace itself is never going to be the most comfortable thing you ever wear, but the idea is to prevent that curve from deteriorating to a point at which you need surgery sooner rather than later. And in most cases, we know that it has a beneficial effect. Time of wear, whereas for many years it was always thought to be 23 hours out of 24. Whilst we agree that that is still the gold standard, we now know from research that anything under 16 hours a day really has little beneficial effect. So it's putting you through all the grief and aggravation of wearing it with little effect at the end of it. So now the statement really is minimum of 16 hours and upwards. If you can't really wear the brace for 16 hours for whatever reason, it really isn't going to have any beneficial effect for you. So the statement I now say is 16 hours and upwards. 23 is still the gold standard, and hopefully you can wear it for that length of time. Once the brace has been fitted to you, I then contact the individual consultant involved and let them know that it's been fitted. They then call you back in a specific time to take an X-ray of you in the brace, where they will check the brace cob angle in brace compared to as it was out of brace when you were initially prescribed for the brace. Then we just follow you up as and when necessary, and it's that easy.